This conference will now be recorded.
Okay, so we are recording the presentation, and it will be added to our website going forward. And let me just first welcome everyone to the Lupus Society of Illinois' Lupus and Pregnancy presentation webinar with Dr. Zineb Auhab from Loyola University Medical Center. Is that correct, Zineb? Is that how you say it? Is it the University Medical Center? For some reason, your audio seems to, I don't know if you've muted, but there's no audio all of a sudden for you. No. Okay, so hopefully she'll get that fixed in just a second. So welcome everyone to the Lupus Society of Illinois' Lupus and Pregnancy with Dr. Zineb Auhab from Loyola, who's going to be presenting. I did first want to go through just a disclaimer. This event is for educational and informational purposes only and serves to benefit our mission. The Lupus Society of Illinois does not provide medical advice or recommendations. This information should not substitute or replace expert medical care. Before making changes to your medical care, consult your qualified healthcare professionals familiar with your medical condition and health status. This event is being recorded and will be archived on the Lupus Society of Illinois' website. And I also wanted to let everyone know our next educational event is coming up on Saturday, October 26th. It's our third annual Rush Lupus Clinic and an LSI educational event, and it's at Rush, and it's from 9:30 to 1. It's a live event. We have 3 presentations, and then we have built-in breaks for networking sessions. And I hope everyone is able to join us for that. And RSVPs are recommended, but not required. So now I am going to see if I can. Zineb, can you hear me?
Yes. How about you?
Okay. Okay. So I couldn't hear you.
I needed to enter that pin, the audio pin.
Oh, okay.
I entered it, and it's fine now.
Oh, it's fine now. Okay, great. So just so everyone knows, as we present, if you want to, please keep your lines muted. We will open it up for questions as at the end of the event. If you have questions, you can also, there should be a chat button. You can send a chat as well, and I'll keep an eye on those. But really, we'll probably save questions until the end. And so now, without any further ado, I'm going to present Dr. Zineb Auhab. She's originally from Morocco and attended medical school at Hassan II University of Casablanca. She came to Chicago and completed her internal medicine residency at Stroger Hospital. She's currently an assistant professor of medicine, Loyola University Medical Center, Division of Rheumatology. Zineb is very interested in lupus in general and lupus health disparities in particular. She looks forward to contributing in education about lupus symptom recognition and early referral to rheumatologists. And without any further ado, Dr. Auhab. There you go. I am sharing my screen, and I think you have to accept it, and then we should be off to the races. Oh. There you go. Wonderful.
Wonderful. Thank you, Mary.
Thank you.
Good evening, everyone. I'll be talking today about lupus and pregnancy. So I'll devote a little bit of time to lupus itself, and then another part on pregnancy and women with lupus. So as you know, lupus is a disease that strikes predominantly young women in reproductive years, between 15 and 45 years of age. So that's when there are questions and concerns about pregnancy and conception. And that's when we also see lupus commonly starting or flaring. In 1970s, most women with lupus were told not to become pregnant because of the risks of complications. But for most women with lupus, pregnancy and a successful pregnancy is actually possible. About 10% of pregnancies can end in a miscarriage, and risks of pregnancy in lupus patients are true facts and involve both the mother and the fetus in terms of complications. So how do we define lupus in general? It's an autoimmune disease of unknown etiology. So that means it's a state of inflammation of the whole body, and it can present very differently from one person to the other. Symptoms are very variable. It can affect basically any organ system you can think about. It can be very mild, it can be very severe, or anything in between. In general, it is characterized by episodes of flares. And what I mean by flares is when the disease is active and causing symptoms, and periods of remission. Remission means when the disease is quiet and inactive. And this can culminate in irreversible end organ damage over time. The diagnosis of lupus is mainly based on clinical symptoms, but also laboratory changes or abnormalities, and those are mainly antibodies, and those are kind of proteins that we check in the blood. A little touch on health disparities in lupus. It is a known fact that lupus affects commonly young female with a ratio of 9:1. So for every 9 females that are affected by lupus, there's only 1 male that's affected by lupus. It does affect specific racial and ethnic minorities. So we know that lupus is generally more severe in African Americans, Hispanics, and Asians. It also has worse outcome when it is associated with low income and poverty, and that can be explained by a difficulty to access care, taking medications, affording medications and appointments, follow-ups. And when it comes to clinical manifestations, I have that little picture out there just for you to imagine the organs that can be affected by lupus. And this is not comprehensive enough because it can affect many other organs. In general, it commonly affects the skin, and that's what we call malar rash or discoid rash. It can affect the brain, so inflammation of the brain, seizures and strokes and things like that. It can affect the lungs. It can cause inflammation around the lungs or inside the lungs or blood clots in the lungs. It can affect the spleen, the joints, so inflammation of the joints, kidneys, very important organ and commonly affected in lupus, where it can where it can become inflamed and can cause people to go on dialysis if it's not treated in time. In the blood, it can affect the blood. It can cause anemia. It can cause low counts. And there are a lot of tests that we do to diagnose lupus. Clinical symptoms, I like to think about them and divide them into 3 categories. Things that we see on the outside. That means when you look at somebody, when we examine a person with lupus, we can see some findings on the exam. Things that happen inside, and those are manifestations that we cannot see when we talk to the patients, but if we do tests, we will be able to see those abnormal findings. And finally, intangibles. Intangibles meaning complaints that patients with lupus complain about, but we are not able to prove them on exam, but they're still there. So lupus intangibles are things like fatigue, brain fog, achiness, depression, joint pain. So those are things that patients complain about and they feel, but we're not able to feel them on exam. Lupus on the outside are things that when you see the person, you will tell objectively that there is something wrong. So the first picture I have out there on your top left is a rash on the face that's very common in lupus, the butterfly rash. The second picture in the middle has Raynaud's, which is the white and blue discoloration of the fingertips in response to the cold. And the picture on the top right is another severe type of rash that we see in lupus. It's called discoid rash. The picture on the bottom is another type of rash of lupus. We see the redness on the cheeks. Other examples, just to give you an idea, hair loss, it's called alopecia, and deformities of the fingers, as you can see on the picture on your right. Lupus on the inside are things that we see when we do tests. For example, the picture on the top right is a simple X-ray of the chest that shows fluid in the lungs. So that person typically would have some breathing issues, cough, or chest pain. And when you do those tests, you will see that there is fluid around the lungs. The picture on the top left is a slide on a piece of the kidneys that shows a lot of inflammation in the kidneys. And that's what I talked about earlier with inflammation of the kidneys in lupus. Picture on the top, on the bottom left, is an electrocardiogram, which is tracing of the heart that can show some abnormal findings if there is inflammation around the heart. Picture on the bottom right is a CAT scan of the brain that shows that white little part, that white shadow that you see is a bleeding in the brain. So lupus and fertility, because lupus predominantly affects women of childbearing age, there's always this question about fertility and outcome of pregnancies with lupus. So fertility in lupus does not appear to be altered by the disease itself. That means people that have lupus don't have any different incidence of pregnancies compared to people that don't have lupus. But fertility can be affected by some other things, like getting some medications for lupus flares, for example. Some medications can affect fertility, especially those strong agents that we give, strong medications we give through the IV for very severe lupus. Most commonly would be the form of lupus that would affect the kidneys or brain. So that medication called Cytoxan can affect fertility and decrease chance of conception in the future. And once women with lupus are pregnant, they do have higher maternal and fetal complications and risks compared to pregnancy in people without lupus. So how do we determine this prognosis of lupus in pregnancy? We generally do not recommend pregnancy if lupus is active, because that has been shown to be a poor prognostic factor. So if somebody comes in with planning to get pregnant in the future, we generally recommend that lupus should be quiet and inactive for at least 6 months prior to pregnancy. Best to be even over a year to make sure that the disease is really quiet. Because, and the reason is, when lupus is active during pregnancy, there are risks for miscarriages, for decreased childbirth or growth at birth. So they may have small babies as opposed to normal weight babies. And they are at risk of getting more lupus flares themselves. The mother is at risk of lupus flares that can cause organ damage during pregnancy. And also medications are kind of little bit limited when the person is pregnant, because we want to choose the medications that are less harmful to the baby. Active lupus at the time of conception is a strong predictor of adverse outcomes. And once we know a person with lupus is pregnant, we do recommend a multidisciplinary approach. That means that person should follow with everybody that needs to be involved in her care. That primarily would be the rheumatologist, her obstetrician or OBGYN, primary care doctors, and even the OBGYN. We usually recommend the high risk or something super specialty in OB/GYN called maternal fetal medicine, and those are OB/GYN that are familiar with autoimmune diseases, so they can help us monitor and make sure we provide the pregnancy goes as good as we can. This slide is a little complicated, but I'm gonna make it simple for you. The reason I put it in there because I wanted to show you how lupus patients compare with non-lupus people. So the first picture on or graph on your bottom left shows compares pregnant females with lupus with pregnant females without lupus. So the top lines in purple are lupus patients, and the bottom dotted lines are for non-lupus people. As you can see, mortality in terms of the fetus and the mother are both increased in people with lupus compared to people without lupus. And the picture or the graph on your bottom right shows you compares the incidence of C-sections and eclampsia and preeclampsia. Those are complications that can happen in pregnancy when it starts causing high blood pressure and counts can drop and things like that. So both of those incidents have increased incidence in people with lupus compared to people without lupus. So just to give you an idea that there are some risks and potential complications when we are comparing the two subsets. Also, on the other hand, so we've been talking about pregnancy and outcome of the babies, but on the other hand, the woman that's pregnant and has lupus has an increased risk of lupus becoming active and affecting the organs. About 30% or a third of people, so around one out of three of people with lupus will have active lupus during their pregnancy. What are the risks and things that can make one person more susceptible to the complications and increased lupus activity compared to another person? So the first risk factor is active lupus. That's why I said earlier, we recommend at least 6 months of quiet disease before pregnancy. History of kidney involvement. That means if a person with lupus already had kidney inflammation from lupus, this is a high risk factor for complications or, again, reactivation of lupus during pregnancy. First pregnancy is also a risk factor, and that's, I think it's most likely because we don't know how this person specifically would behave during pregnancy. Multiple flares in the years prior to conception. So that's another risk factor, because when you have multiple flares, that means the disease is susceptible to flares easily during pregnancy. And stopping some medications. So Plaquenil or hydroxychloroquine is one of the first-line medications that most people with lupus would be on, and that this medication has protective effect against lupus reactivation and organ involvement. So if the person stops Plaquenil or hydroxychloroquine before pregnancy, they are at risk for developing active lupus and therefore complications of lupus and pregnancy. So now, since we talked about all of those potential risks and things to monitor for, what do we do? How do we advise people with lupus when they are planning on conceiving soon? First question is pregnancy acceptable or unacceptable? Is it the right timing? Is lupus being quiet? Did they have any problems with their kidneys before? Are they taking the right medications? So once we determine the pregnancy is acceptable, now we have to move to the second step. What medications are you on? And are those medications harmful to the fetus? Should we stop some of them? Should we change some of them to others that are less harmful, and so on? Now, you should keep in mind that if the disease is quiet and you decide to get pregnant and all of a sudden you stop all medications, the disease can become out of control, and then you'll get another risk factor, which is active disease prior to pregnancy. So we have to be careful about how to manage medications before pregnancy. Ideally, if the medications are safe for pregnancy and the disease is quiet, we generally continue the same medication so we don't make any changes and we're not risking having a flare during the pregnancy. Now, other things to be aware of and to review prior to conceiving, any previous blood clots. So blood clots they are commonly seen in lupus, and they can be associated with another autoimmune disease called antiphospholipid syndrome. And before conceiving, we need to check for that syndrome with some blood work. If those tests are very high, then we have to be aware of them so we can prevent some other complications such as blood clots and miscarriages due to blood clots. We also asked about previous pregnancy complications, for example, having small babies, preterm babies, miscarriages, preeclampsia that I talked about earlier, when the pregnant woman gets a very high blood pressure and proteins in the urine. So those also can increase chance of worse outcome in lupus. So we do ask about all of that. And once we determine that the pregnancy is acceptable, we review all the medications to make sure that they're all safe to be continued during pregnancy and during lactation as well. I have this chart here that I like about medication management during the pregnancy and lactation. So the first column is about the medications that we commonly use in lupus. The second column is about what to do during pregnancy, and the third column is about lactation management. So corticosteroids on the first row is corticosteroids, and those are steroids like prednisone or IV steroids like Solimedrol. So during the pregnancy, we try to use the lowest effective dose because there are potential complications from high-dose steroid use, mainly cleft palate, which is a hole in the mouth of the baby. So those are potential complications that can happen. So we try to avoid those. We try to keep it to the lowest effective dose, if any, and same thing during lactation. NSAIDs are anti-inflammatory medications like ibuprofen, Aleve, Mobic, Meloxicam, Voltaren, or diclofenac. So those are all anti-inflammatories. We prefer to discontinue them during pregnancy and lactation. Baby aspirin or aspirin in general, we can use a low dose if indicated, and there are certain indications when you want to use low dose aspirin, and those are primarily blood clots, and that's why I mentioned earlier that we should check for those antibodies. If they're present, we have to be aware of them because they can affect some of the medications we recommend during pregnancy. Here, the next row is about stronger medications that we use for lupus. The first one is azathioprine or Imiran. The second one is cyclosporine, and the third one is sulfasalazine. Those are all medications that we use for lupus, joint pain, sometimes kidney disease. So those are safe to continue during pregnancy and during breastfeeding. The next row of medications are methotrexate, cyclophosphamide or Cytoxan, mycophenolate or Sulfep, leflunomide or Arava. Those are medications that have potential risks for the baby, so we do not recommend them. They should be discontinued, not right before pregnancy, but many, many months before conceiving, to make sure that they're out of the system by the time the person gets pregnant. Okay, the next row is about hydroxychloroquine or Plaquenil. So that medication is actually very, very important. It should be continued through pregnancy and breastfeeding. We do not recommend stopping it. It's been proven to be safe, and stopping it may increase risk of flares or active disease during pregnancy. Now, warfarin is a blood thinner, and some people are on it because they've had blood clots in the past. During pregnancy, we recommend switching that to heparin. Heparin is an injection, and that's because warfarin has potential risks on the babies. The recommendation regarding using it during breastfeeding is not clear. So what do we check before conceiving? As I mentioned earlier, clotted antibodies are very important to check before and to be aware of their status. We also check other antibodies that we see in lupus, and specifically, I'm going to mention anti-SSA or anti-SSB antibodies, and those are important to know because if they're positive, there is risk for fetal heart block, and that means arrhythmia or some change in the heart rhythm for the fetus, and it is important to recognize because it can cause fetal death or and sometimes we have to put a pacemaker before the delivery so the fetus can go through the delivery and the labor and pressure and all of that. Kidney function, it's important to know, as I mentioned earlier, if the kidneys are not functioning normally, that by itself is a risk for complications during pregnancy from lupus. So we check blood tests for kidney function and urine tests as well. We check blood counts because lupus can cause the blood counts to go low. So, for example, white count, hemoglobin, platelets, all of those need to be monitored during pregnancy. And liver function tests. The liver is also a vital organ that's important to monitor during pregnancy. So, to summarize what I've been talking about in terms of risks that are associated with pregnancy and lupus. So we talked about risk of miscarriage, and that's usually associated with those antibodies that are called antiphospholipid antibodies. Risk of preterm birth and intrauterine growth retardation. What I mean by this is risk of having small babies compared to normal. There is also risk of heart block in the fetus, and we talked about those antibodies, anti-SSA, anti-SSB antibodies. Also, risk of neonatal lupus. Neonatal lupus means lupus that manifests or that has symptoms in the newborn. That's typically what you would notice is a newborn with a rash and count being low. That's usually associated with the presence of those antibodies, again, anti-SSA, anti-SSB, because they cross placenta and they can go to the fetus blood and cause the same symptoms in the fetus. The good thing about neonatal lupus is that it is a disease that's due to those antibodies, those proteins made in the mother's body that cross the placenta and get to the baby. So after birth, the baby will get rid of those proteins gradually, and it generally takes about 6 to 8 months for the baby to get rid of the antibodies and the proteins from the mother. So we would expect after 6 to 8 months that this neonatal lupus will start to get better on its own. That's because the baby is getting rid of those proteins that are causing problems. And then finally, maternal risk. So we talked about lupus becoming more active during pregnancy, causing complications or important organ involvement. So measures to take to prevent complications from lupus. So whenever, even if there is no risk of blood clots, or even if you don't have a history of blood clots, before you get pregnant or you start conceiving, you have to be screened for those clotting antibodies. And that's something that our rheumatologist and hematologist will do. And the OBGYN, if they know you have a history of lupus. If you have a history of previous complications during pregnancy, you should talk to your OB/GYN and to your rheumatologist about it. And that's because they will need to make a decision regarding blood thinners and baby aspirin to prevent future complications in the next pregnancies. And pregnancy in lupus is considered high risk. So we do recommend very close monitoring of the mother and the baby. And that's why they need to be following with the maternal fetal medicine. And those are OB/GYN that are specialized in high risk diseases, and they know what to monitor and what to look for closely during the pregnancy. Many babies are rescued by early C-section when there are signs of poor blood flow through the placenta, which is the organ that keeps the baby attached to the mother's body. And sometimes, there's no clear consensus or clear agreement on what to do when the person has never had any problems, but those antiphospholipid antibodies are present in the blood. But we make the decision based on what we think is the most beneficial to the person, case by case. So there are, again, some risks for having small babies or babies that are born before term. And the most important risk factor is active lupus. Active lupus is the most common risk factor for getting an early delivery before term. Also, if we use high dose prednisone, that also increases the risk of having preterm delivery. And if there is kidney disease, then also there is that risk as well. Antiphospholipid antibodies, those proteins, can also cause preeclampsia, that disease that state that I talked to you earlier about, when there is high blood pressure and proteins in the urine, and sometimes there is in some situations they have to deliver the baby early to protect it against further complications. Also, people or women with lupus that are pregnant, they do get monitoring with ultrasound to measure the weight or to measure the size of the baby and estimate the weight. So we know if there is risk for small babies and after delivery or not. And those are very important for monitoring. If I'm sure you're gonna have questions about why would the lupus flare during pregnancy and be quiet while it was quiet before. We have many potential explanations for that, but there is no one explanation. There are multiple hypotheses that we have. Most likely, it's because during pregnancy there is strong shift and change in hormones, especially estrogen. as well as some proteins that cause inflammation. Because there is this significant change, lupus can flare during pregnancy. When there are flares during pregnancy, we've noticed that blood counts, those counts that we talked about, and kidney disease are more likely to be affected. So how do you plan for pregnancy to be on the safer side? We prefer that conceiving coincides with periods of good disease control. We do change some medications prior to the pregnancy to make sure that they're all safe for the baby and that they're enough to control the disease to make sure it's not going to flare. We screen those antibodies for blood clots and anti-SSA and anti-SSB antibodies. We monitor the baby, the heart of the baby, and the weight of the baby with ultrasounds. And because this is complicated and high risk, we do recommend high risk obstetricians to be on board to help with good management. So we do, in general, although people or women that are pregnant that don't have lupus don't need like monthly checkups. We do recommend for women that have lupus that get pregnant to have a monthly checkup with their physicians to make sure that all their blood work looks fine and all the urine tests are fine and the baby is developing properly and everything else. So in general, we usually have rheumatology, obstetricians, and hematologists, if there is a risk of blood clots, all communicate on a regular basis to make sure that things are progressing the way we expect. Obviously, common things to avoid, or just common things for everybody, including people that are not pregnant. But if there is a question about lupus, we always want to avoid sun exposure. And if you go into the sun, you always want to have sunscreen on every 2 hours with high SPF, and even better, have long sleeves, pants instead of shorts, and big hats to avoid sun exposure. We know that sun exposure can cause flares of lupus. We do not recommend smoking because smoking can cause flares of lupus. Smoking also can prevent medications to do their job, so they work less in people that smoke with lupus compared to people that don't smoke. We recommend healthy diet, a lot of vegetables and fruits, and avoiding processed food, fried food, sugary food, to make sure, healthy diet is vegetables and fruits are more anti-inflammatory, whereas the fried food and processed food can worsen inflammation in general. And we recommend regular exercise as tolerated, and regular activity, even with pregnant women, to make sure that they stay active to help them have a better outcome with the delivery and the baby. All right. With this, I have 15 or 17 minutes for questions. If you have any, I'm here to answer them.
Okay.
And thanks for listening.
Thank you for the presentation. Does anyone have any questions?
Okay. Sinel, this is Patricia. What is the likelihood of of a baby having lupus, especially if the baby had a neonatal lupus? Is any scientific proof that this baby may be more vulnerable to developing lupus in their
lifetime
years?
Yep. Yes, that's a good question, Patricia. Neonatal lupus in general is due to those proteins crossing the placenta from the mother to the baby. So once the baby is born, the body will get rid of those proteins gradually, and lupus symptoms would get better. Now, your question is is this baby at risk or at higher risk of developing lupus in the future?
Yes.
Now, all individuals that have family members with autoimmune diseases are at higher risk of developing autoimmune diseases in their lifetime. It may not be lupus specifically, but it could be something else like rheumatoid arthritis or scleroderma or thyroid autoimmune disease. So any kind of autoimmune disease compared to people that don't have anybody in their family with autoimmune diseases.
Okay. Thank you.
You're welcome.
Okay. Does anyone else have anything? Okay. First, I want to say when I first started at the Lupus Society 13 years ago, one of the first calls I got was from a woman who said that her doctor had counseled her to have an abortion because she got pregnant and she had lupus, and she didn't want to. I guess he'd counseled her previously as well. She didn't realize that that you could have a successful pregnancy when you had lupus. So this is all really new information, right? Like there's still information coming in about lupus and pregnancy, but you can successfully have a baby while pregnant with lupus is one big takeaway for me. And then the other thing is, I know that there's complications. Miscarriages are common, or at least not uncommon. What are the chances of if you've gotten pregnant, if you have lupus and you've gotten pregnant successfully and you've had a miscarriage, is there any data on a second pregnancy, what the success rate is on that?
So that's where that's where the role of those antibodies, the clotting antibodies, comes in. So when we have a history of miscarriage, even one or no miscarriage, but to keep your question into perspective, if you have a history of one miscarriage, let's say, we do definitely want to know about those antibodies. If those antibodies are strongly positive, that means very high, the chance of getting a second miscarriage is significant. And that's when sometimes we recommend the baby aspirin and sometimes even anticoagulation, like heparin shots as soon as they know they are pregnant, so they can keep their blood fluid and prevent blood clots. Because some of those miscarriages happen because there are blood clots in the placenta.
Okay.
So the pregnancy does not progress. So if we know this is the case in that person and they have high titers of those antibodies, we in some situations recommend being on blood thinner to prevent miscarriages in the future. I mean.
So it's possible.
People, yeah.
I'm just saying. I'm sorry to interrupt you, but like in terms of data, like I know it's all new, so there's not a whole lot of data mining. Yeah. But is there like maybe a 75% chance of a subsequent successful pregnancy, or is there any kind of?
Yeah, I see what you mean.
Yeah.
Yeah, I don't. I'm not sure we know.
Okay.
I'm not sure we know the exact number.
Okay, but it is possible. And it seems like if you have a miscarriage, the data that your doctors learn from that might help you with a second successful pregnancy?
Absolutely.
Okay, so that's fair to say. So there's hope, because it can be so discouraging to experience that, My heart goes out to,
No, I agree.
Yeah.
We've had patients that had multiple miscarriages, and once we know they have those antibodies and they're elevated, and once they are on anticoagulation on those blood thinners, they are able to carry a pregnancy to term.
Okay, so that's very hopeful. Okay,
I have a question about the antibodies. Every time I go to the rheumatologist, I think the only antibody that we check is the double-stranded. In order to check to see if I'm okay for the other antibodies, do I request it? How do I go about that?
So those antibodies, you mean the clotting antibodies?
Yes, I never saw that on a test when he ran the test for me.
Okay. So those tests, we generally check them at the beginning. When we make the diagnosis of lupus, we want to know what the rest of the antibody bodies look like. So we do check them at the beginning. And if there is any discussion about pregnancy, we again check them. But if there is no, if the person is not thinking about conceiving and we already know the status from the beginning, there's no need to keep checking them every time.
Okay, got it.
Because generally
And
they
as
don't check very quickly. But yeah, the double-stranded DNA is what we monitor for the lupus activity.
okay. And as far as the medication to discontinue, I saw that you said it should be months in advance. Is there like a specific month in advance prior to pregnancy?
Yes, generally we recommend at least 3 months. It depends on the medication because some of them last longer than others in the body when you stop them. So it depends on the medications, but at least 3 to 6 months before conceiving. That applies only to the ones that are high risk of complications.
Okay, thank you.
Zineb, can you talk a little regarding the daddy's role? We have seen very few men with lupus. However, there is any way that their fertility is impacted by lupus?
So the data that we have right now, as far as I can tell, is that lupus itself does not affect fertility. So a person that has lupus has the same chance of getting pregnant as a person who does not have lupus. But there are some medications that can cause this fertility to become compromised, and that's mainly Cytoxan. It's applicable to women as much as well as to men, but with women they have just a limited number of eggs. So if that medication wipes out all the eggs, then there is no more chance of getting pregnant. But in males, they can recover with time, and then they can go back to normal. But again, there is a chance that Cytoxan affects fertility even in males.
Oh, that's interesting.
And what does,
When you're,
go ahead.
no, I'm sorry, please go ahead.
I was asking, what does creatinine play in pregnancy? Because I heard from one of the doctors about your creatinine in your blood being too high.
Yes, creatinine is a blood work that we use to check the kidney function. A normal creatinine is usually 1 or lower. As it gets higher, the risks of getting complications during pregnancy are higher. And typically, we recommend that if a creatinine is over 2, pregnancy should be avoided. But that's, creatinine of 2 would be compatible with an advanced problem in the kidneys.
Okay.
Yeah. So it is important to monitor.
I have a question in regards to the antiphospholipid syndrome. So I have that, and my husband and I just recently experienced a miscarriage because of the blood clotting. But I'm trying to see if we try again, is there a predetermined dosage of the heparin that should be injected? Because I was doing injections. So I'm like, can they predetermine the dosage of heparin you should be taking while pregnant?
The heparin dose is determined by weight.
Okay.
So it's going to depend on the weight. Yeah.
Okay. Any other questions? So when you are talking to someone who's a patient who's thinking about getting pregnant, what's the first thing you talk to her about?
Yeah, that's important. That's a very a delicate kind of discussion. So generally, what we start with is how long have you had lupus, and has it been bothering you? Has it been active recently? Did you have to be on steroids, just to have an idea of how active the disease is? Then we also want to know about previous pregnancies. What was the outcome? Were they normal? Were the babies term? Were they born with normal weight? And how many miscarriages, if any? How late during pregnancy? Is it early miscarriage, first trimester versus second or third trimester? And then we check the blood work, as we talked about earlier.
Okay. When do you then recommend an OBGYN, or do you, like, is there somebody, or do doctors, rheumatologists in general have, like, do they refer someone to a specific OBGYN, or would that be up to the patient? Yes, you usually do.
Absolutely.
Okay.
Because,
yeah.
And not any OBGYN. With people that have lupus, we recommend maternal-fetal medicine, which is a subset of OBGYN that deals with high-risk women that are pregnant.
Okay. But that would actually probably, I would think, make it easier for your patient, because you wouldn't have to, you'd already know who somebody who's already familiar working with lupus patients is always going to be beneficial to someone with lupus, right? And another question, and I also have heard with women who have lupus and they've had successful pregnancies, one pregnancy their lupus may be very active, and another pregnancy it'll be like lupus took a vacation. Have you heard about that, or is that common?
Yes, it is.
Yeah.
And it's very hard to determine when lupus would become active versus not, because there are so many factors that contribute to causing the disease to become active all of a sudden, including stress, change in hormones, as I mentioned toward the end of the presentation, change of estrogen and prolactin. All of those hormones can easily cause lupus to flare. Sun exposure, surgeries, or stress in life. There are many things that they all culminate and can cause a flare. And again, it's very variable. We try to keep medications the same, so at least we know that we're not making any changes that by itself would also contribute to a flare. But there's no way to tell really for sure, 100%.
Right, so they don't know, even though it might happen, because whenever it's been told to me, it's always, they talk about it like it's a phenomenon, like it was the craziest thing that with one of their children, their lupus went haywire, and the other one was, but they really don't know there may be no way to know, right? Like it just literally may be the course of the disease for whatever reason.
Correct.
Right?
And also, correct. But they could have changed their medications in between pregnancies. That's also hard to tell. So one set of medications controlled the first one, then they went off later on, and then they got pregnant. Their disease may not be optimally controlled, and it was just waiting for that estrogen change to flare, for example. So it is hard. It's case by case. It's hard to tell.
Okay. Any other questions?
Yes, one of the indicators of a healthy pregnancy usually is exercise. What level of exercise should have a woman who is lupus when you have all these risks on the side?
Activity should be as tolerated. Simply walking, for example, may be enough. Yoga, so nothing like jumping around, but gentle exercise. But staying active is very, very important because that helps pregnancy go smooth. The woman is ready for a good labor and delivery. It's very, very important to stay active.
Great.
Great.
I have a question here. Somebody wrote a question. Natalie, I'm positive for antiphospholipid. I'm under the care of a maternal medicine specialist, the care of a hematologist, although it's stem cell blood clots.
Hello?
Okay, I'm just reading the question.
Oh, I see. I'm sorry.
Followed by the second charity. Unnecessary. What can? Yes, I see the question. So, so if you have antiphospholipid syndrome and you are following up with an OB/GYN and they're comfortable, you know, it depends on the level of comfort of the physician. If your OB/GYN is comfortable and has experience with antiphospholipid syndrome, then it's okay to just continue with them. Now, if they're not comfortable, then they will get help from hematology because they also see antiphospholipid syndrome. So it's not wrong not seeing a hematologist, but it depends on the level of comfort of your OB/GYN.
Okay. Any other questions? Okay. Do you have any final thoughts, Dr. Oheb?
Well, I think it's at the end of the day, you know, you really have anybody, any woman with lupus who's planning to conceive in the near future needs to have a serious discussion with her rheumatologist and OB/GYN about the implications, because it's case by case, and things need to be looked at in details before making the right decision. And once they are pregnant, they need to follow very closely with monitoring blood work on a regular basis to make sure that if there is anything that goes off, it's taken care of early before it causes complications. That's really my take home point here.
Okay. All right, wonderful. Well, thank you so much for presenting. I really appreciate it. I know how busy you are. I really am grateful that everyone who was able to call in was able to call in. I hope to see all of you at the event at Rush next month, because next month is October. It's hard to believe, but it is. And until then, if you have any questions, always feel free to contact me. If you have a question for Zeneb, you can forward it to me and I can forward it on to her. Thank you so much for calling in. And this entire presentation will be on our website within the next couple of days. And with that, I will sign off. I will wish everyone a good night. Again, I will thank Dr. Oheb for your presentation, and everyone have a good evening.
Thank you.
My pleasure.